عن coronary artery disease أو stable ischemic heart disease. محاضرنا إن شاء الله دكتور صلاح أبوسين. زي ما عودناكم دائما في سابا مشاركاتكم معنا، لو في أي أسئلة ممكن تتوجهوا لل Q&A section، وممكن تستعملوا الchat function لأي تداخلات. تفضل دكتور صلاح وشكرا لك.
السلام عليكم. شكرا مازن. سامعني كويس؟
واضح يا دكتور صلاح.
تمام. عندنا مشاركة غير الزوم ولا حنكون بس زوم الليلة؟
أنا مشارك على مشاهيرين برضو على فيسبوك لايف.
أوكي تمام. أوكي فطبعا try to keep this as interactive as possible. المحاضرة دي الهدف منها إنه information that you learn from it you can immediately implement in a low resource settings. فنحن كان أخذنا المحاضرة الأولى the first lecture was acute coronary syndromes. Now we're going to go more into stable ischemic heart disease. So these are patients you see more likely in the outpatient clinic who have a stable presentation. So we're not going to talk about acute coronary syndrome. We will focus, as I said, on things that you can implement immediately. يعني نحاول نركز على الحاجات اللي ممكن نطبقها مباشرة في المريض. طبعا this presentation, like the one before it, is meant for internal medicine, family medicine, emergency medicine, primary care. This is not for a specialized audience. That's why we're going to focus on the basics. So the learning objectives, by the end of this activity, the learner should be able to understand the approach to evaluate a patient with suspected stable ischemic heart disease, understand the role of exercise ECG stress testing in diagnosis and management of stable ischemic heart disease, and understand guideline-directed medical therapy for patients with ischemic heart disease, stable ischemic heart disease. So we start off with the problem. So we have a 72-year-old male, has no significant past medical history. He comes to see you in clinic. He has noticed over the last several weeks that he gets chest pressure on walking up 2 flights of stairs. Once he stops walking, the chest pressure subsides. His heart rate is 80 per minute, blood pressure is mildly increased, 150/70, with no abnormalities on physical examination. ECG shows normal sinus rhythm. So the first thing, what would you like to do next? And I give you 4 choices. Refer for cardiac catheterization, start clopidogrel, start digoxin, none of the above. هل ممكن نعمل بول مازن؟
ممكن أو ممكن يستعمل برضو Q&A أو chat function.
اوكي.
لو في أي شخص حاب يشارك، بس you can use the chat or Q&A section and just type your answer. Okay, so we have none of the above. We have 2 choices for none of the above.
Okay.
Selections.
هاي ظهرت لك في الفيسبوك؟ اوكي نرجع السؤال، ما في معنى. اوكي ده السؤال يعني. بعد ذاك نمشي للأسئلة ذاتها اللي هي A, B, C or D. هل في إجابة ثانية غير D? Does anybody want to think there's another option? اوكي تمام. طيب نمشي للسكند بروبلم ودي هي الإجابة الصحيحة فعلا. It is none of the above. We'll go through the slides and explain why that's the case. طيب problem 2, 55-year-old female with no significant past medical history, presents to your outpatient clinic. She has noticed over the last several weeks left shoulder pain. So she has left shoulder pain on exertion lasting for a few minutes. Once she stops walking, the pain subsides. Heart rate is controlled, 80 per minute, blood pressure 130/70, no abnormalities on physical examination, and her ECG shows normal sinus rhythm. So what would you like to do next? Options are the same as before, بس غيرنا هنا. Start long-acting nitrate, in addition to either doing cardiac cath or starting clopidogrel, or none of the above. So we have and then a bit more spread, much.
Yeah, we have few answers for B, couple for D, and one for C.
Okay, all right. So this one, we'll go through it again and in the presentation. So this is good to know. Problem 3, 72-year-old male, diabetic. Now he says he has stabbing pain over the right side of the chest that lasts for less than 5 seconds at rest. He has no symptoms on exertion. His pain is reproducible on chest palpation, nothing else abnormal on examination, and his ECG shows normal sinus rhythm. So what do you think about this one? And as far as the options, check echo, exercise ECG stress test, do a cardiac cath, or none of the above.
Okay, we have one choice here for D. Another one is B.
Okay.
C, so I think it's spread
Yeah.
over.
Also, we have a bit of a spread. Okay, very good. So, so when we talk about the spectrum of CAD, as we explained earlier, acute coronary syndrome is actually going to be number 5. Okay. So what happens is you get a ruptured plaque, you get activation of the coagulation cascade, and then you get either complete occlusion of the vessel, which results in an ST elevation MI, or you get an incomplete occlusion of the vessel, which either causes a non-STEMI, where you have positive troponin, or no ECG changes, or no troponin increase, with or without ECG change, and that would be unstable angina. So this area is going to be your acute coronary syndrome. Okay, so as I mentioned earlier, we're actually talking about stable ischemic heart disease, and we're going to be focusing on patients who have symptoms. Obviously, there are some patients who do not have symptoms of ischemic heart disease, but they do have the condition. So these patients, when we talk anatomically, they have a fixed stenosis in one of the epicardial vessels, and that is the one that causes them to have symptoms. There are some other subtypes who don't have epicardial disease, and that would be microvascular ischemia, but that is beyond the scope of this talk. Okay, so then when you come to evaluate symptomatic patients who have ischemic heart disease, the key thing is really in the history. So the history is how you make the diagnosis or how you suspect the diagnosis. So then as far as when the patient comes in, when you're taking the history, there are 3 things you need to figure out. The description of the chest pain, the association or whether the pain is provoked by exertion, and whether it's relieved by rest. These are the 3 components that you should be able to decipher from the history. The typical chest pain is one where you have substernal chest pain lasting for a few minutes, brought on by exertion and relieved by rest. And these are the 3 factors. So if the patient has those 3 factors, he is said to have typical angina. However, if he has 2 out of these 3, so if the patient has chest pain, which is characteristic in quality and duration to that of angina, and it is brought on by exertion, not necessarily relieved by rest, or not brought on by exertion but relieved by rest, or 2 out of these 3, that would be atypical angina or atypical chest pain. If the patient has none of those or only one, then it is more likely to be non-cardiac chest pain. And that's very important in terms of what you do next. If you have someone who has typical angina, provided that they have, then you, based on these three changes, you can define their pre-test probability. So the pre-test probability of having stable ischemic heart disease is affected by age and gender. So men who are older are more likely to have the condition based on whether their symptoms are typical, atypical, or non-anginal. Women and younger age are those are less likely to have the condition. Okay. So that's when it comes to doing exercise ECG stress testing. Okay. So if we take our first patient, he was 55-year-old male in the mid-50s who had chest pain on exertion, which was relieved by rest. He has typical angina, right? So if he had typical angina and he's a 55-year-old male, he'll be around in this area, okay? So the pre-test probability is about 32% based on this graph. Now, obviously, this graph changes from one population to another. This is based on European guidelines, so they might have a different prevalence to what you see in your daily practice. Once a patient is suspected to have typical angina, then you might go down what's called the Bayes theorem, and that will tell you which way the stress test will take you. For all intents and purposes, to keep it simple, for patients who have typical chest pain, then you can establish the diagnosis from the history. So if you have a middle-aged male or female who comes with chest pain on exertion that's relieved by rest, and the pain is typical in its location, by definition, that patient has stable angina. The role of stress testing in that patient is for risk stratification. If you have a patient who has atypical chest pain, meaning that it doesn't fit the right description, your next step is to do the exercise ECG stress test to establish the diagnosis. So if the test is negative, then that rules it out. That means he does not have the condition. But if the test is positive, then the patient does have that condition. Okay. So if we go to the exercise ECG stress testing indications, it could be diagnostic for atypical angina, where you have intermediate probability of stable ischemic heart disease, where a negative stress test rules out stable ischemic heart disease, while a positive stress test confirms the diagnosis. If the patient has typical angina, then the test is used for risk stratification. The limitations of doing exercise ECG stress testing is the patient's ability to exercise and the presence of an interpretable ECG. Let's pause here and see if people followed what I just said. ممكن تفتح المايك إذا يمكن في ناس عندها مايك مازن. لا البوينت دي شوية كومبلكس يعني ما.
Okay. Okay, so if anybody has any question, you can just raise your hand and I will allow your mic functionality.
ما في زول رفع يده.
No.
Okay, طبعا. طيب. So this is an example of an ECG. So this is a baseline ECG in a patient who's presenting for a stress test. Okay, and this is what it looks like at peak exercise. So can anyone tell me what they see? What new change they saw on the EKG or ECG? So this was the ECG before. Okay. And this was the ECG after. Okay, very good. So there is ST depression. Yeah, this is fairly pronounced in the inferior leads. That's definite ST depression. You actually see it also in the lateral leads. Okay, so this is an abnormal ECG stress test. It's an abnormal ECG stress test. So this patient had atypical chest pain, meaning that he did not have the typical presentation of angina. This test will support the diagnosis of stable ischemic heart disease. Okay, and that will help you give the diagnosis. If the patient had typical angina, then the value of the test will be to risk stratify. Risk stratify. And that's why the test has two roles. يعني انت اذا انت شخصته من اخذ التاريخ المرضي للمريض، الستريس تيست حيساعدك عشان تعرف درجه الخطوره كم. اذا انت ما كنت متاكد من الهيستوري العيان ده عنده انسداد في الشرايين التاجيه ولا لا، الستريس تيست بيساعدك في التشخيص. اوكي، اذا العيان عنده typical history of stable ischemic heart disease and their stress test is negative, it does not rule it out. Okay, it just shows that his risk is lower. ودي مهمة من ناحية بتاعت in terms of the subsequent management. Okay, so the idea behind Bayes serum is that to know your pre-test probability. So your pre-test probability is defined by what you take from the history. Based on that, you can put a pre-test probability. So if the patient has typical angina, he's going to be more towards a high pre-test probability. If the patient has atypical angina, it will be towards the middle. If the patient has non-cardiac chest pain, or then he'll be lower down in pre-test probability. And this is where you stand. So after the test, after your test is done, if the test is positive, then it moves your pre-test probability, the post-test probability upwards. فإذا أنت كنت فاكر إنه 50% احتمال الزول ده يكون عنده انسداد، لو طلع ستريس تيست بوزيتيف بيرفعك لفوق، ولو طلع نيجاتيف بينزلك تحت. فإذا أنت أصلا عندك هاي probability قبلها، التست ما حيغير في التشخيص. إذا كان عندك low pre-test probability قبالها، التست ما حيغير في التشخيص. فعشان كده في الناحية بتاعت التشخيص exercise ECG stress test is most valuable for diagnosis in people who have intermediate pre-test probability. فده المفهوم بتاع Bayes serum. So that's a bit different from other aspects of interpretation of tests. Okay. The reason why it's important is because the test performance is not as high as others. Okay. That's why you're dealing with exercise ECG stress test. You're looking at 70% sensitivity, and it's a relatively low sensitivity, low specificity when you use it. So you have to put the history with the stress test. You have to interpret them together. Okay, so that's the first principle to understand in terms of diagnosing stable ischemic heart disease, is to know the pre-test probability. Patients with high pre-test probability are diagnosed based on the history. Patients with intermediate pre-test probability, atypical symptoms, the stress test supports your diagnosis if it's positive and rules it out if it's negative. Okay, you can do other things with stress testing that improve the performance, and that's by adding imaging. أنا ما حدخل في الإيميجينج كتير لأنه ما متوفر كتير في السودان، يعني عشان كده that's why exercise ECG stress test is available in Sudan, but it's underutilized. That's why one of the things we want to teach you from this series is to increase the utilization of available tests. يعني الحاجات اللي عندك استفيد منها أكتر. You can take a history and you can do an exercise ECG stress test. So the more the better you know your tools, the better you can use them. That's the idea behind stressing this point. Okay.
دكتور صلاح، في سؤال انه the EKG changes with are they supposed to be ST depressions only or even T-wave inversions makes it a positive test?
Yeah, so this is بتخش في التفاصيل بتاعت interpretation of ECG stress testing, and that's kind of beyond the talk. We can set up, it takes about a 30-minute talk, but it's a good question. So generally speaking, when you look at exercise ECG stress testing, the information you get out of it, I think I have a slide next. Yeah, I have a few slides about it. But generally, just to answer that question, ST depression, duration of exercise tolerance, and the presence and absence of symptoms are the three main variables that help in interpreting the exercise ECG stress test. Okay, T-wave changes are not as significant, but it's not normal. So if you have somebody who has an upright T-wave and they develop new T-wave changes, that's not a normal finding. Okay, and that goes back to raising your suspicion of CAD. Okay, right. Contraindications, and this is important because if you see a patient who has atypical symptoms, you might consider sending them for a stress test. It's important to know what are the contraindications. So if they have a recent acute MI, if they are a high-risk unstable angina, you should not do the stress test because you would provoke arrhythmias and bad things happen. If they have uncontrolled cardiac arrhythmias, if they have symptomatic severe aortic stenosis. Practically speaking, if you auscultate a patient and you find a abnormal, if you hear a murmur, especially in Sudan where you have a high prevalence of rheumatic heart disease, better get an echo first, okay? If there is no murmur, then don't worry about it. But if there is a murmur, get an echo first before you send the patient for an exercise ECG stress test. Practically speaking, it's very difficult to be extremely confident about your auscultatory skills to differentiate whether or not somebody has significant valvular disease. So I think practically speaking, if you hear a murmur, get an echo, okay? Especially when you have very high prevalence of rheumatic heart disease. If the patient has heart failure, you shouldn't stress them. If it's uncontrolled and symptomatic, you should also probably get an echo first. Anybody who has an acute PE, acute myocarditis, acute aortic dissection. So generally speaking, exercise ECG stress test is for stable patients. It's not for ACS patients or ACS or any urgent conditions, okay? So it's an outpatient procedure. If the patient comes with an MI and you're thinking they may need a stress test for risk stratification, make sure it's ordered by a cardiologist, okay? And that's a safety thing. Relative contraindications, left main coronary artery stenosis, you won't know it unless the patient has severe symptoms, okay? You won't suspect it. So people who have CCS3 angina, meaning that severe angina, then these are a different kind of patients who do not necessarily fit patients with stable ischemic heart disease. So if a patient tells you over the last couple of weeks, I get chest pain whenever I get up from the chair, this is more along unstable angina. Okay, so these patients, you probably don't want to stress them. Simply because they will go into, they have a high risk of bad things happening at the time of a stress test. Moderate stenotic lesions are a relative contraindication. If you find it on echo, don't stress the patient, let the cardiologist do that. Other conditions, severely uncontrolled high blood pressure, you should control it first before you send the patient for a stress test. Tachyarrhythmias, bradyarrhythmias, hypertrophic cardiomyopathy, again, you would suspect it based on a murmur. Also, one of the important things, and this applies a lot to some of our population in Sudan, people are extremely overweight, elderly, cannot coordinate. Usually you see it as a combination. It's always worth trying them on a stress test unless it's impossible, okay? يعني زول أصلاً بيمشي بعكاز وحركته ثقيلة, you can make that bedside assessment. You probably shouldn't put them through the stress test because they might fall off. Pretty common sense يعني. And high-grade AV block is also a relative contraindication. Okay. طيب نجي للquantification of risk, and this is kind of it's an old slide. It's very old, but I think it's important. It's still valid when you're using exercise ECG stress testing alone, and this is where it comes to assess prognosis. Okay. So you look at, the first thing you look at is the level of ST depression. So the more ST depression you have, the worse your prognosis, and the more symptoms you have, the worse your prognosis. تقوم توصل مثلا إذا كان عندك عيان عنده 3 ملم ST depression وعنده exercise limiting chest pain، فبتوصل الاثنين سوا هيعمل لك يعني تقريبا هيتصلوا هنا تقريبا، كويس؟ بعد ذاك بتشوف الاكسرسايز MET how much they exercise. في طبعا برضه بتجيك بهناك دي بتعرفها من الديوك بروتوكول. فمثلا نقول the more MET you use the better your prognosis. فكل ما طلعت فوق كل ما كان outcome أحسن. فبتقوم توصل الاثنين سوا. فهنا الإسكيميا reading line وهنا الميد. فإذا كان هنا 5 وهنا somewhere here إذا وصلتهم بخط هتجيك زي 9%, which is very high annual mortality. And their 5-year survival is very low. لكن مثلا إذا كان عيان عندك فوق هنا مثلا عنده 1 mm ST depression وعنده مثلا non-limiting symptoms, الإسكيميا reading line بتكون هنا وقلت ماشية زي 13 أو 17 مت, then إذا وصلت الخطين سوا بيجيك 1%. المهم فيها إنه as the level of ST depression is worse, the more symptoms you have, the less exercise you do, your worse your mortality is. بعد ذاك في سكور ثاني اسمه Duke Treadmill score, which also uses the same variables: duration of exercise, extent of ST depression, and the presence or absence of symptoms. These are the 3 variables that you use to risk stratify patients. Okay. فأنت لما تكون عملت الستريس test, there is 2 things you want to know: is the stress test normal or abnormal, and when it's abnormal, how bad is the risk? Is the patient, is it a low risk, is it a high risk, or is it intermediate risk? Okay, that is going to tell you what your next step is. الحاجة المهمة is a patient عنده low risk stress test with stable angina, then he should be fine with medical therapy. لكن إذا كان high risk, then you might think about doing something more, which is usually cardiac catheterization. Okay. The point that I want to make here is there's a lot you can do before that patient goes to cardiac catheterization. Okay. And that is a good way to go into the medical management. Objectives حقت medical management هدفين: you want to improve their prognosis and you want to reduce symptoms. نحن عادة كويسين في 2, لكن مرات number 1 دي we forgo it. لكن that's important. Okay. So your objective are to improve prognosis and reduce symptoms. And prognosis is here, right? So this is your prognosis. أنت هدفك تقلل المورتاليتي. تقلل المورتاليتي. Okay. That's what your goal from improving prognosis. And symptoms, you want them to do more. Okay, you want them to have less symptoms so that they can be more active. In terms of improving prognosis, there are 2 things you do. One of them is lifestyle and medications. For the purpose of this test, بس الناس زي تركز على البيسك, يعني تركز على الحاجات الأساسية. And that's why I'm not going to go into the in-depth discussion of the different medications, and I'm also going to focus on medications which I know are available in Sudan. طبعا عندي مشكلة ثانية بتاعت availability of medications. But there is still medications you can use, and there are some medications you should not use. Okay. So the other goal is to reduce symptoms and also make people do more. كان في سؤال في Q&A يا مازن؟
There is a question, sort of a specialized question about how to analyze the 4 stages of stress test.
ال 4 stages ما داير analysis, هي في النهاية بتطلع المكنة براها. It's automated. For the machine, you set it Bruce protocol, it just goes up يعني each stage every 3 minutes. That's how the machine is set up. Okay. طيب نمشي بعد ذاك the other thing. So دي بالنسبة أنا خدت دي مهمة لأنه one of the things that happen is smoking unfortunately is quite prevalent. يعني يمكن ما في specific studies about how many people smoke in Sudan, لكن it's fairly prevalent, and I think the trend is not a good trend. Yeah, the general trend in Europe and the United States is that people are smoking less. Okay, and that resulted in a lot of reduction in acute coronary syndromes and ischemic heart disease, and people live longer as a result. لكن في السودان في شريحة كبيرة جدا من الناس are actively smoking. عشان كده one of the things is important, one of the main things you can do is work on that, or at least advise the patient. Okay, and this is one of the things that can help patients understand the importance of smoking cessation. So this is a study that showed, they looked at all the studies as far as smokers. On average, stopping smoking adds 11 years. Okay, and that's for women 11 years, for men 12 years. And that can be important for patients as far as you communicate to them. It makes, if you take a population of people who smoke and a population of people who don't smoke, you find that people who smoke, people who never smoked, on average live 11 years longer. Okay, and that's 11 years of productivity. So that's an important marker for most people, because most people don't want to die. Okay. Right. So as far as your role as a physician, because it's important, most patients have difficulty stopping smoking, and most people are actually unable to, do not successfully stop smoking. So the first thing you should do as your role is ask about it. That is the key. You should know whether your patient is smoking or not. And it's a straightforward question. Do you smoke or not? Okay. If they do smoke, you should advise them to quit. Okay. And then you assess their readiness to quit. إذا هو الزول أصله ما حيغير رأيه ما تضيع زمان. لأنه talking to somebody who's not ready to stop smoking is not usually useful. They have to be ready for it. And after they're ready for it, then you can help them. But if they already don't want to engage in a conversation about stopping smoking, don't try to push them. Just advise them that this is something, and most people understand the harm of smoking. So usually it's not news to them. It just becomes, for those of them who are contemplators, they're thinking about it, a conversation with you may be the thing they're waiting for to stop smoking. And then it becomes a matter of finding the tools that are used that are that they can find helpful to stop smoking. So then the next step is for them to stop. But there is a lot of things you can do. As you could see, there are 3 things you can do. You can ask about it, advise them to quit, and then assess readiness. Okay, so that's one point. Now the other thing is about the healthy diet. Now that's another important thing that you can also do, and that does not involve spending money. Okay, and that's by giving them basic advice about what they can and what is a good diet. الحاجات الأساسية بتكون الحاجات الضارة اللي هي زي المشروبات الغازية والعصائر. These are big things which they can stop doing. And then the other things that they can also stop doing is cut their consumption of grains. Increasing the consumption of fruits and vegetables may not be easy. A lot of it is associated with an increased cost. And you can find all this in the link which will be provided to you. And these things are important because they matter a lot. Okay, they matter a lot and they don't cost. They're actually more difficult to do, but they are a major investment because you don't spend, from a financial standpoint, they're a major investment because you don't spend money on it. And generally, it is associated with much better outcomes. The other things are physical activity, and that's also gender impacted, depending on some cultural factors may limit the amount of exercise women can perform. Men have it easier in Sudan. And then, of course, maintaining a BMI of less than 25. And for that, the key thing is really, a lot of it is education. The first education is to know how much they weigh. A lot of patients may not know how much they weigh. Having a weighing scale and giving them a number to quantify how much their weight is can make a big difference for some people, because they don't even know how much their weight is. So the first thing you can do is measure their weight. You can make another assessment of their height. You don't have to exactly quantify it, but you can know fairly easily, in most cases, whether a patient needs to lose weight or not. And the patient is usually aware of it. Giving them a number helps them plan. طيب, نجي بعد ذاك للمedications, and I focused only on the class 1 indications. I only focused on class 1 indications. Which these are things which you should do. So the first thing is aspirin, okay? Patients who have, and we're talking about the patients we saw in the initial problem, somebody coming in who has history of chest pain or an angina equivalent, and you diagnose them with ischemic heart disease, they should be on aspirin, okay? Clopidogrel should not be prescribed unless the patient cannot take aspirin. And that's very important. في ناس كثيرين في السودان حايمين باسبرين وكلوبيدوغريل as a combination. Don't do that. Okay? Do not do that. You're just adding cost without adding benefit. You should give them aspirin. Only if they're intolerant to aspirin do you give clopidogrel. Okay? And that's important. As far as lipid lowering drugs, all of them should be on statins. All patients with ischemic heart disease should be on statins. And then what statin you use, generally speaking, depends on your LDL level. You should probably prefer the high intensity statins like atorvastatin and rosuvastatin. They are associated with an incremental cost. Something is better than nothing, but many patients have insurance which covers it, and it's useful medication to be on, its value is proven for a long period of time over a large number of trials. ACE inhibitors, ARBs, especially if the patient has hypertension, heart failure, or diabetes, that would be another medication for them to be on. Okay, and these are all long-term medications. So you're already looking, before we go into symptoms, these are the medications every patient with a stable ischemic heart disease should be on. They should be on aspirin, statin, and ACE inhibitor if they're hypertensive. Okay. Yeah, actually I skipped, there's one I skipped, which is actually the, as far as symptoms. So as far as symptoms, there was a slide about it. The two medications you should have as a class 1 indication and as a first-line medication in all patients with stable ischemic heart disease is beta blockers or calcium channel blockers. Okay. Practically speaking, you should, in the guidelines, European guidelines give them the same weight. As far as which beta blockers to use, the ones which are available are bisoprolol and carvedilol. There are some other subtypes. Bisoprolol, carvedilol, and metoprolol, especially the XL formulation, are also given in heart failure. So if you want to remember one pill that you want, or two pills, as far as beta blockers, would be bisoprolol and carvedilol. Calcium channel blockers that you can give are amlodipine. Amlodipine is widely available, and also sustained release nifedipine. So these are the ones for symptoms. The other medication which you should also have, but unfortunately is not available in Sudan, is sublingual nitrate. Sublingual nitrate. So if you, so to recap, the medications that every stable ischemic heart disease patient should be on: aspirin, statin, and an ACE inhibitor if they're hypertensive, a beta blocker or a calcium channel blocker for symptoms, and sublingual nitrate. Okay, sublingual nitrate. Right. Any questions so far?
Okay. So far, I don't have any in the section, and if any of the attendees have any questions, please feel free to type them in the chat or in the Q&A, or you can always raise your hand and you'll get a chance to ask your question in person.
Okay, based on what we said, so what do you want to do? من غير ما نشوف الإجابات. But this is back to our patient who has a 72-year-old male. So what kind of angina does he have? So is this typical, atypical, or non-cardiac? So that's the first question. Okay, very good. So it's typical. Okay, excellent. So now based on this, what do you want to do? Based on what you learned, what's your next step? So he has typical angina. He is 72 and his blood pressure is 150. You already examined him. You already did an ECG. What are you going to do next? Pretest probability. Okay, what is his pretest probability? It's going to be high, medium, or low based on his symptoms. Okay, very good. So we know it's high, صح؟ فعشان كده, what are you going to do next? So what will the stress test, what is the purpose of the stress test? الهدف شنو من stress test؟ هل هي التشخيص أم for risk stratification? For which purpose? Okay, excellent, very good. So I think that's the key point. I'm happy that you realized it. So the key point is risk stratification. So you schedule for a stress test. What do you want to do between now and the stress test? داير تعمل شنو؟ قدامك روشتة هتكتب لي شنو؟ Okay, aspirin, very good. Low dose aspirin, low dose aspirin. Okay, يعني 70 في 3 انواع في السودان، في 70 وفي 100 وفي 81، بس ما تكون full dose. Full dose aspirin just increases your risk of bleeding. تمام، كتبت aspirin. ثانية Beta blocker, very good. So you give him bisoprolol, he has blood pressure is 150, bisoprolol 5 milligrams once daily. Tani? ACE inhibitor, good, because you have room in the blood pressure. Detol 5, it's covered by his insurance. Okay, statin. Excellent. So you give a statin like atorvastatin, and then you try to get him a PRN nitroglycerin. So these are the key things: aspirin, statin, ACE inhibitor because it's hypertensive, and beta blocker for symptoms. Okay, so then he goes for the stress test, and he walks for about 5 minutes, doesn't get any ST changes. جاك راجع بالتقرير حتقول له شنو؟ So will you stop the medication or will you continue the medication? Exactly, very good. So you keep the medication, and Jack Tani بعد 6 شهور follow up, he's doing fine. Okay, will you continue the medication at 6 months? Yes, exactly. So you continue the medication at 6 months, and you continue it long term, as long as the preventive medication is going to be lifelong. Beta blocker, you may cut down the dose at some point, and you can put it back on again if he develops symptoms. طيب نفس المريض جاك وقام عمل stress test, and the stress test is abnormal. It's an abnormal stress test. So what do you do next? التقرير قال لك abnormal. قال لك مشى 2 minutes or whatever يعني، بس قال لك abnormal. دي الملخص بتاع stress test. So what are you going to do? Yeah, so actually, يعني, what I want you to do is to refer to cardiology. Okay, at that point, if you're not a cardiologist, refer to a cardiologist for further management. Okay, there's a lot of debate about the value of cardiac catheterization in people with stable ischemic heart disease. The most recent trials have shown that even in patients who have a significantly abnormal stress test, doing cardiac catheterization, putting stents, and doing bypass surgery is not necessarily better than medical therapy. And that's important. But this is beyond the scope of this talk. As long as you've started the patient on medical therapy, as long as you've done the stress test, if the stress test is abnormal, refer to cardiology. Okay. طيب. Clopidogrel has no role unless the patient is intolerant to aspirin. Based on the data that I gave, digoxin has no role in treatment of stable ischemic heart disease. Okay. طيب نمشي للبروبلم اللي بعدها. طيب فدي شويه مختلفه. دي قالت لك she's 55-year-old female, does not have chest pain. She has left shoulder pain. On exertion, relieved with rest. Vitals are stable. So what do you do next? Okay, exercise ECG. And what is the purpose of stress testing in this patient? Are we doing it to diagnose, or are we doing it to risk stratify? Yeah, so this time the test is diagnostic, right? So you do the stress test, and you find the stress test is markedly abnormal. Or just say abnormal. What do? You refer to cardiology, right? If the stress test is negative, it makes your diagnosis less likely. It makes the diagnosis less likely. You may look into other causes of her symptoms. دي شوية كده atypical لأنها يعني it is concerning because it's also important to note that women usually have atypical symptoms, so they might need some more details. But definitely your next step is going to be exercise ECG stress test. You don't have enough data to refer her to cardiac cath, so that should not be your first step. Clopidogrel, as I said, is not a first-line agent unless the patient is intolerant to aspirin. Long-acting nitrates are used as second-line agent. So you have to give a beta blocker or a calcium channel blocker, and maybe even both before you go to nitrates. Long-acting nitrates, طبعا short-acting nitrates are used for relief of symptoms. طيب.
دكتور صلاح في سؤال كان عن the first problem. In regarding hypertension, why not giving the patient calcium channel blockers because of his over 55 years of age instead of ACE inhibitors.
ما ده الكلام اللي قلناه الأول صح؟
أيوة.
طيب what is your depends on what your goal is, okay? So one of your goals here is control of blood pressure, right? So you want to control the blood pressure. You also want to treat CAD symptoms, and you also want to improve prognosis. Come on. Right. In this case, the medication you're going to use are going to be the one that achieves most of these objectives. Okay. So in this case, beta blocker and ACE inhibitor would be my choice. ACE inhibitor is going to give me the prognosis, is going to give me the blood pressure control. Beta blocker is going to give me symptoms, and it's going to give me the blood pressure control. Does that make sense? I would use a calcium channel blocker as number 3. That would be my order. Beta blocker, ACE inhibitor, and calcium channel blocker as 3rd line.
Okay.
Because you're number 1, so you want symptoms and you want prognosis. So beta blocker is usually your 1st line. لو اديته amlodipine as 1st line برضه ما غلط. لكن I would give ACE inhibitor probably. You probably need to give 2. I guess if you do amlodipine and ACE inhibitor, I guess it's not wrong, but that wouldn't be my preference. My preference would be beta blocker and ACE inhibitor. ما أعرف رأيك شنو يا مازن.
صحيح, I agree. يمكن I think إنه the question was more alluding to the appropriate use criteria. Calcium channel blockers sometimes are considered as appropriate use criteria to be anti-anginal. Like as Dr. Salah said, you always want to look at how you can help your patient from all aspects. So I think ACE inhibitor and beta blocker would be the start.
Okay. تمام. طيب أهم بالنسبة للبيشنت ده 72 قال لك عنده stabbing pain over the right side of the chest lasts for less than 5 seconds. Less than 5 seconds. He has no symptoms on exertion, and if you palpate the chest, you can feel it. So what are you going to do? هو عنده 72 وعنده diabetes وخايف لأنه جاره مات بهارت attack. So what are you going to do next? Yeah, so this is non-cardiac, right? So non-cardiac, don't stress them. Okay, so it's non-cardiac, don't stress them. You can focus on the risk factors, and you control the diabetes, control the blood pressure, and give whatever is indicated for that purpose. But don't send them for stress testing. Okay. Come on. So that's I think that's the end of the presentation. So these are some of the sources. And they're fairly heavy text, so you might try to find something which is a summary. Okay.
Okay, شكرا دكتور صلاح. It's a very important topic بالذات إنه فيه 2 aspects. فيه an important early identification, risk stratification and diagnosis, وبرضه فيه cost saving للatypical pains. So it's a very important subject to grasp for our colleagues in internal medicine, family medicine, and emergency medicine. If anybody has any question, please feel free to share it with us through the chat or Q&A. Okay, I think we covered most of the questions during the presentation, Dr. Salah. As always, thank you very much for your contribution. ما قصرت, ويعني you presented many important topics in field of cardiology in a simple way that takes into consideration our resources in Sudan. Thank you, and on behalf of myself and SAPA, we appreciate your help as always. Thank you, Dr. Salah.
Welcome. Assalamu alaikum. Shukran.